Yes.
Okay.
That was part of mine.
So the Office of Minority Health is a newly established office at the Centers for Medicare and Medicaid. And we were just formally entered into the register. You know, it's just government jargon for being in the books officially, I think at the end of August. And our focus and our goal is, of course, to look after minority health. $17 billion, it costs Medicare and Medicaid $17 billion a year, health disparities. That number is going to grow to $220 billion in about 15 years. A lot of the issues of minority health is preventive care, as we've talked about. Diabetes, cardiovascular issues all impact minorities at greater rates. I mentioned the diabetes program, diabetes self-management training program. That particular preventative benefit, there is a barrier to it. It's a $150 copay, but it's still the most underutilized preventative service. You could get paid now if you know, I mean, you can get that care now, but even people that have been are not using the benefit. They're not using the benefit. So we need advocate. We need you to help promote the services that we offer. And I think like I said, CMS is becoming aware of that realization of how to use it. And a couple of different things. As part of the OMH, we're an unfunded mandate, which means they didn't give us any money. But we sit at the table, and we tend to be very tenacious about the goals of our office, trying to make sure that we can use the resources that have been given to us to integrate health disparities programs into the offices of innovation, Medicare, CMCS, which is Medicaid, CHIP programs, and things like that. So a couple of things that you may be aware of, in addition to what the Affordable Care Act did for health disparities, and it's also done care transitions. I don't know if you're familiar with Section 3026 of the Affordable Care Act. It's also a place where hospitals and the community are joining together to lower readmission rates, hospital readmission rates. And guess what we need there? Community health workers to make sure the people are following the protocol necessary when they check out of the hospital. So I thought I'd throw that section of the law out in case you want to take a look at that. There's also the health exchanges. Are you familiar with that? Come into play in 2014. Health exchanges is going to increase the amount of people that have access to health insurance in 2014. But these are people that have never had access to health insurance before, so they don't know how to navigate through the healthcare system, and they're going to need someone that can help them with that. So looking futuristically, I believe there's a proposed rule of the standards that out there right now for your review. The final rule goes out next year, but it's something to keep an eye out for. Let me see what else I have for you. Oh, and then the HRSA, you've done a lot of great work. I was very impressed with the work that Sergio presented today, and the membership, the advisory board, everything that went into that. In terms of a curriculum, there's a lot of areas of focus. If you were going to prioritize things that you want to look at, emergency preparedness is a good area for you to look at. And you're already doing great work with the diabetes, prenatal care, the Pew, what is that, Pew Center talks about the maternal home health care, visiting. These are the areas where we see community health workers working in a non-technical environment. So these are areas that you can continue to develop curriculums for. HRSA has, I don't know if you've seen this on HRSA's website. If you go to hrsa.gov and you Google the community health worker, 3 things come up immediately. One is a workforce study. The other is a bibliography of evidence of articles that discuss the benefits of community health workers. And the third thing is a toolkit. And the toolkit has several different models and definitions and kind of how to work out the, you have a question? HRSA is the Human Resources Services Administration, hrsa.gov.
That's good. If any more foreign languages that get spoken up here, feel free to ask a question so we can get them translated into English.
Yeah, that's good. So they have a toolkit, so they kind of walk you through like how to develop curriculums. And in terms of collaboration and partnership, that's an excellent piece of advice. You definitely need to work together, both as an organization, but also with other facilities in the community leaders. If you think about CMS and who we work with, you talk about HUD, you talk about HRSA or the FQHC, the Federally Qualified Health Centers. You need those in your pocket. It's a big marketing campaign, but just go the Agency on Aging, the AAAs. They conduct a lot of, they get grants and services, and they could use your services to help recruit or promote the preventative services that they happen to be getting a grant for. So there's a lot of ways to go about it. Government is kind of big and hard to navigate for anybody. So I was just hoping that if I provided you with a couple of website resources, at CMS, you Google the Innovation Center, that'll tell you about the grants that come out of there for opportunities where you can where you can look at what's being offered and figure out a plan for how to integrate into those programs.
So you bring up a question that was on my mind about technology and innovation. I know there's money that's been through the Affordable Care Act for health information technology, right, for HIT. Is there anything available for people who are actually in homes to be able, whether it's through PDAs or through home-based computer systems? Is there money out there for folks to be able to interact in the home with medical professionals, other places, using some of the more modern technology?
First, just to clarify just a little bit, HIT came out of ARA money, not ACA money. Okay. It's two different pots. Okay. But in terms,
the acronyms for this?
ARA is the American Recovery.
Stimulus package,
Stimulus.
or AKA the stimulus package.
The stimulus package, okay, sorry. Yeah, with the world of acronyms. I've only been in government for a year, so I'm still getting them straight, the alphabet soup. But in terms of, we are working with providers to get on board with meaningful use of electronic health records. And eventually, there'll be a push, and I can see community health workers being of service for personal health records. But in terms of working out of the home on the computer, specifically, no, I don't have any access to any information that would lead me to believe we're doing something like that.
If anyone else does, I was on a panel recently with another physician who talked about how sometimes, particularly people who live in remote rural areas, doctors can begin to do initial assessments, or nurses can do initial assessments of patients before they drive 30 or 40 miles into a hospital.
Well,
to get some
actually,
sense of-
I'm sorry, I misunderstood. I didn't know that was for the physician, but telemedicine, yeah, I thought of, yes, I'm sorry. Yeah, but telemedicine is something that I believe OMH is creating a program on telemedicine for diabetes so that they can conduct the diabetes self-management training via the phone, but the patient still has to show up at the doctor's office once during the course of a year to make sure he understands how to inject himself with insulin. But yes, they are.
Anyone else on the technology? Okay. So we had a little bit of stimulus package versus the healthcare bill. We hear a lot of negativity about the healthcare bill. Are there other things that are in the healthcare bill that any of you are working with that people in this audience should know about in terms of helping them do their job better?
Or maybe people out there might be doing such stuff too. I'm not aware of anything.
This isn't necessarily in the healthcare bill and health reform, but I would say that there is significant interest from HRSA regarding the training of primary care physicians, primary care providers, and specifically, there are grants that support this out of HRSA, but specifically in collaboration or working with community health workers. So at Bronx Lebanon Hospital Center, we have a HRSA grant that supports our effort to train family medicine resident physicians and medical students working with the community health worker model. So that's one small area that seems. We also have a grant that's through our FQHC, Bronx Lebanon Integrated Service System, which actually directly funds the several of our community health workers to function as general CHWs in the community, and that was recovery dollars.
And the one thing I hate, I'm sure everyone else here hates it, is paperwork. And a lot of these grants and also you focused on financing in your work group. Are there resources and places where people can go to in the audience who can be helped with navigating all the different assessments and paperwork that they would have to go through to be helpful?
I'm going to jump on that one. I was actually, I know everyone wants to take, after Elisa made those few comments, we all want to take her back to the office and pick her brain, right? So if her family finds out she's kidnapped tonight, you might give me a call, because truth be told, that what she just said in 3 minutes is, everything we would take a graduate course, take 6 months to learn, but that's very valuable information.
Oh, good.
Are there any questions in the audience? We can start to do this. We got great resources up here. Everyone has everything that they need.
Jamal, while we're waiting, maybe I'll pick up on one other. As we're waiting for the first question, I'll make one other comment, and that is, don't stop collecting your outcomes data, whether it's health outcomes, looking at how much did you lower the blood pressure or the hemoglobin A1C with the diabetic patients, or if it's just what we call in our program touches by the community health workers, how many times they interact with the patient or how many times they conduct a shared medical visit. Collect that data. If you're not doing it, start doing it. It's critically important for us to promote the community health worker effort. A little bit more difficult aspect of data and information that needs to be disseminated is the return on investment. We've heard a little bit about that. If you do a literature search and you look for return on investment for the CHWs, there's data out there, but it needs to be further substantiated. So connect with a university, an organization, someone, the New York State Health Foundation, to support your research efforts, and then get it out there, whether it's in a poster or a presentation. So that data continues to be very, very important.
I want to thank you all for coming here today. This has been an extraordinary day, a momentous day, an important day for us and our workforce. I was perplexed to hear Jackie tell you that it was only halftime. I was really counting on a vacation. But yes, it is so true. That is sage advice for us. Time to cowboy up and make something happen with these recommendations. We also have a lot of work to do in forming our statewide association. We're going to work very closely with the Rochester Association. I know there are some people who registered from Westchester here. If so, please reach out to us. We'd love to get together with you. I just met Jose from Albany. We'll work to find some CHWs in Albany and help them get organized and join our federation. We look forward to continuing the work of our leadership advisory group, because that has a lot of work to be done too. And in our visions, we really look to develop a permanent structure, a CHW Institute, a CHW Center, that will continue to guide the maturation and implementation of these recommendations under CHW leadership. So we look forward to seeing you next year. Stay in touch with us, join join our movement. We've been given some really sage advice here. I'm gonna repeat Yvonne's and Doug's call to you to tell your stories. The stories are real. Stories are data. Stories is research. It's important. The story that we read to you today of Maria Murphy's story is in a scientific journal. It was published in the Journal for Ambulatory Care last month. That's a peer-reviewed scientific journal that contains a story of a CHW and her spirit. So those stories are important, and it's scientific data. Tell your stories, publish your stories, document your stories. And we're actually going to do a little bit after the conference. I need to implore for you that the challenges before us are large. We can't minimize that. I can't do it alone. You can't do it alone. We really need to take control of our destiny. We really have some guiding principles now that can help to motivate us that way. But we really need to come together. As much as we advocate for others, it is now time for us to be our own CHWs. If we don't take determination of our practice, somebody else will. It has already happened in other states. So we really need to be alert for that. We really need to be conscious of that, and it's really time for us to step up and take control of our own lives. It is time to advocate for ourselves. So I need to thank, I want to thank all our funders, our speakers were amazing. I want to thank the panelists, especially all of you were amazing. Thank you for traveling down to the city to spend time with us. I want to thank our staff. My staff in particular is just amazing. April, Sally, Yasmin, I thank you all so much. I want to thank our volunteers who helped make today happen and happen correctly. I want to thank Ani and her crew for helping us to have a permanent record of what happened here today. And I want to thank you all from the bottom of my heart for making this such a beautiful day in my life. Thank you.